Yes.
Yeah, please go on.
So thank you everyone for attending our 12th Lincolnshire ENT Grand Round. We have a special guest today. I think so it's with a very popular topics and interest topics. So I can see that we have started with 30 persons that were attended it, and it seems to be that there are more to come. So we have Professor Alexandre Karkas. Is it right? Karkas?
Right.
Yes.
Karkas.
Yes, Karkas. He's a professor in the and a chair of the Department of Otolaryngology in University Center San Diego, Medical School Jan Munt University, and he is one of the European eminent otologists who do skull-base and cochlear implants. So the topics today is the atraumatic cochlear implant. Thank you, Alex, for coming and acceptance of our invitation.
Thank you, Abdurrahman. Hi, everyone. Thank you for attending this webinar. And I know we all had a hard day, so thanks for staying with us. So I'm very honored to participate into the Grand Rounds of the United Lincolnshire Hospital. And I will try to describe very briefly the atraumatic cochlear implantation from the preoperative workup to the postoperative follow-up. Why do you have to do an atraumatic surgery? Because it was found that when you preserve residual hearing, we will have a better speech discrimination and better speech performances with the cochlear implant. Whenever there are microtraumas induced during insertion of the electrodes, they provoke a loss of excitable nerves, fibers, and this will impede an optimal electrical stimulation to the acoustic nerve. And we should not forget also that in the pediatric population, we should preserve the sensory and neural structures for a possible future reimplantation. So when the child will have 40 or 50 years, we might need to reimplantate on him or on her. So we should preserve the cochlea with its sensory and neural structures. Preoperative imaging, what are the guidelines of the French Society of Otolaryngology and Radiology? We'd better do an MRI of the internal acoustic canals to see if there is any inner ear malformation, if there is hypoplasia or absence of the cochlear nerve, as we see here on the left side. And for the adult with the sensory neural hearing loss, we should rule out a vestibular schwannoma, acoustic neuroma, or other cranial lesions, which might need some observation in the future. And also in the post-meningitic or post-traumatic cochlea, we should rule out fibrosis with early signs on MRI earlier than the CT scan. And we also need a CT scan of temporal bones. I know this is not mandatory, but I advise you to do it because it shows the anatomy and the landmarks of the facial nerve of the round window before doing the operation. If you have a translabyrinthine structure, which you should have fracture, you should see where the fracture line, and you can also see a dilation of the fundus or absence of bone partition, which can announce a CSF gusher during surgery. So here we see an acoustic neuroma in an adult who was planned for right cochlear implantation, and here also we see on the same patient mastoid fibrosis. So you might change your surgical approach while seeing this completely sclerosed mastoid. This is a study that we did in the past, and we published in Otology Neurology. with a team of Montpellier in the south of France. So it can help you plan and choose the best electrode array diameter as a function of the exposure of the round window. So if this is the formula, I can share this formula with you later on. So you have the minimal exposure before drilling the bony overhang of the round window niche, and then you have the maximum exposure after drilling the bony overhang of the round window niche. For instance, if you have the small edge, which is 0.3, and the capital H, which is 0.6, you can put an electrode with the 0.5 diameter into the cochlea. So there is also a software made by MEDER, which is called Autoplan. You can measure the cochlear duct length and choose the length of the electrode array which you are using as a function of the cochlear duct length. Just as a reminder, not all cochleas have the same length. The lengths can vary between 28 or 27 millimeters up to 35 millimeters. So if you have a long cochlea and you want to cover all the cochlear tonotopy, you should put a longer electrode array. For instance, in this example here, we have on two turn we have a cochlea which is very long, 36 millimeters. So we have chosen a flex soft which is 31.5 millimeters of length to cover all the tonotopic frequency distribution of the cochlea. This is a work which we are doing with my resident Kelly Daouda, and the work is in progress. Also, on the other hand, if you do a deep insertion, the deeper the insertion, the higher are the forces of insertion, and these forces of insertion increase drastically after 20 millimeters of depth of the cochlea. So here, as you see in a study on a temporal bone, on a model temporal bone model, also when you insert very deeply, you will have a narrower scala tympani. The scala tympani will get narrower as long as you go farther in the cochlea. So scala tympani is large here, and whenever you cross the pars ascendens, the ascending part of the basal turn of the cochlea, the scala tympani becomes more narrow. Yeah, this being said, when you put a longer and deeper insertion electrode in the cochlea, you will have a better discrimination in the long and in the long term, because you are covering all the tonotopic distribution frequency of the cochlea. For instance, here, if you put a short electrode of 24 millimeters, you will not have the physiologic 1,500 hertz, because your electrode will be much more proximal. Whereas if you put a flex soft, which is 31 millimeters, the electrode will correspond to the natural tonotopic distribution of the frequency. So it will the electrode 7 will correspond really to the 1,500 hertz of the cochlea. So you will respect the natural distribution of the frequencies inside the cochlea. If you have residual hearing, for instance, you all know that if you have mild to severe hearing loss, you use a hearing aid. When you have profound hearing loss, you use a cochlear implant. When you have in between, for instance, you have preservation of hearing at low frequencies, mainly above 60 decibels, and you have on high frequencies, you have a great loss of hearing. You can use what we call electroacoustic stimulation or hybrid stimulation, which means you stimulate the low frequencies with the hearing aid, and so acoustic stimulation, and you stimulate the high frequency and the medium frequencies electrically with the cochlear implant. That's why we say a hybrid stimulation. So you will have a bimodal hearing in the same ear. What are the advantages? There are many. So you will have better field discrimination, especially in noise, which we call the squelch effect. You will have a better sound selection and a better signal to noise ratio in the noise. You will have a better quality of sound, the better quality of the pitch of the sound, because it's more natural, and you will have also a better music perception. So whenever you have a threshold below 60 decibels on the frequencies of 500 hertz, you should try to put an electroacoustic system with an acoustic stimulation on low frequencies and electrical stimulations on medium and high frequencies. I will show you an example here. This is a 17-year-old adult male. I'm sorry for the quality of the audio. This is an old paper audiogram. I didn't have the time to digitalize it. So you see, he had preserved low frequencies, and then you had a drastic fall here on the higher frequencies. And even with the hearing aids, you didn't have any correction of his speech discrimination. He even had some distortions whenever you increase the sound stimulation. So this young male did what we call a natural frequency transposition. So he had a speech discrimination only at low frequencies. So he was more and more annoyed by his hearing loss, which was increasing. So we went for an electroacoustic stimulation, and so we stimulated acoustically the 250 and 500 hertz, and all the remaining frequencies were stimulated electrically. So we have put a short electrode with an acoustic ear mold for the low frequencies. But unfortunately, he lost some hearing on the 750 hertz, as you see here. He lost some hearing, and this is the result of the cochlear implant. So all frequencies were doing well except for the low frequencies. So he was not happy with the electroacoustic stimulation. So do you have any suggestion for this patient? You can answer. So what we did, we transformed the electroacoustic stimulation into an exclusively electrical stimulation by removing the ear mold and stimulating the apical frequencies using the electrical system. So the most apical electrodes were activated, and we removed the auricular ear mold, and we had an exclusive electrical stimulation. And see, after 3 months of rehabilitation, he had an excellent result with the cochlear implant. So it is reversible. Whenever you start to stimulate with electroacoustic system, you can go back to an exclusive electrical stimulation by activating the apical most electrodes and removing the acoustic part of the cochlear implant.
So can I ask a question?
Yeah, please.
Alex. So that's mean that you keep the same electrode, but you activate some of them, and then you can deactivate and activate them, or you re-implant the patient.
No, you don't have to reimplant him, and yeah, it's a little bit dangerous. So you can keep the same electrodes and activate the apical most electrodes which were deactivated. That's why we advise that you put an electrode which is not very short, a medium length electrode, just in case you will use the exclusive electrical stimulation. You will have some electrodes which are reaching the cochlear apex in order to stimulate the low frequencies.
I'm just asking because we have some of the audience are trainee or middle grades, so some of them they haven't seen the electrodes and how it works. So that's why sure.
No, you don't have to replace the electrodes. You can do some fitting, and you can perform a new frequency distribution in the cochlea and stimulate all the region of the cochlea electrically by removing the acoustic part of the cochlear implant. So now we will go to surgery. the surgical technique is also important. Some people say, you know, in the past we used to say, yeah, never mind, because anyway the patient has lost his hearing or her hearing, so we can do a surgery without conservation of the cochlea. This is false. You should preserve all the sensory neural structures to have an optimal stimulation of the auditory nerve. So surgical technique is crucial. And then you have also adjuvant treatments, local and systemic, and you can have also intraoperative monitoring. We'll see this later. So surgery, there is a principle which is called soft surgery, which was described by Lenhardt, a German surgeon in the 90s. You should do an insertion of the electrode into the scala tympani, as you see here on this cadaveric model and on a model which I did on microscopic fluoroscopy. So electrode array in the scala tympani. You should not elevate the basal lamina here to preserve the neural structure at this level here. No trauma, so no kinking and no fold over to the electrode array. Otherwise, you will have high impedances. You should not enter bone dust or blood into the cochlea, and you should not suck perilymph. That's why most surgeons, mainly in the USA, abandon the cochleostomy. Because in the past there was a dilemma, because whether you do cochleostomy or round window approach, and the Americans were favorable for cochleostomy, and the Europeans advised round window approach. Now most of the surgeons use round window approach because cochleostomy can induce bone dust, perilymph suction, or blood penetration into the cochlea. So most of surgeons currently do round window approach. So this is a insertion trauma scale, which is used mostly worldwide, described by Trog and associates in Miami. He has French origins. I met him a week ago. So grade 1 is elevation of the basal membrane. Grade 2, and this is a picture I made, is rupture of basal membrane. Grade 3 is translocation of the electrode into the scala vestibuli, and grade 4 is major trauma to the cochlea. For instance, in this case, it's a fracture of the osteospinal lamina, or also a fracture of the modiolus, or rupture of the striae vascularis. So if you have major trauma, you can it's called grade 4 according to the scale. So surgical technique starts with the wide posterior tympanotomy while preserving the facial nerve and the chorda tympani, and you should have an optimal exposure of the round window membrane. So in most of the cases, you should drill the posterior superior bony wedge covering the round window. As you see here in live surgery, chorda, facial nerve, drilling of the bony overhang of the round window. This is the CT scan picture. See, facial nerve is skeletonized, chorda tympani is right here, and you have a direct access to the round window region. So, do you know how is the height of this posterior tympanotomy here? It's in children it's only 2 millimeters, and in adults it's at most 3 millimeters. So that's why it's very, very narrow, and you should use a drill of 1.5 millimeter, a diamond burr of 1.5 millimeters, if you want to preserve the facial nerve and the chorda. So the round window is not that simple. It is a very complex region, as you see here in the Dr. old publication. We have round window membrane is here. We have two pillars, postis posterior and postis anterior here. We have also the fustis in the it's a bone prominence in the floor of the round window, and the anterior part is called the crista fenestrae, which is inconstant. So you see, this is an endoscopic view which I made. I know that Dr. Ibrahim loves endoscopic views of the ear. So this is postis posterior, segment of the round window, postis anterior, fustis. You have here the crista fenestrae, and here you have the subiculum promontory. And you all know the sinus tympani. So you see a very complex region, which is not very regular in shape. And this is also a an image by the microscopic electronic microscopy done by Cochlear and associates. So you see we have the two post-its here and the tegment. So we should drill all this here to have access to the round window membrane. There is a classification from Leong and associates from the Thomas Hospital in London. So we have 4 types of exposure of the round window. First type, you see the round window membrane without drilling the bony overhang. Type 2A, you see 50% of it. Type 2B, you see less than 50%. And type 3, you see nothing. So in this case, sometimes you have to do a round window related cochleostomy. So you go from the round window and you drill anteriorly, or use a fiber optic or a small endoscope to help you see the round window membrane. This is a work done by Roland in Dallas, Texas. So you see, if you don't drill the bony overhang, you have minimal exposure, and your electrode array can hit the modiolus. And so, whereas when you drill the bony posterior overhang here, posterior superior bony wedge, you have a mid-scala insertion, so it's in the center of the scala tympani, and you do not hit the modiolus, so you do not hit the neural structures. This is the anatomic specimen. If you drill more than 1 or 2 millimeters the bony overhang, you can fracture the osteospiral lamina. So we don't want to do this. That's why you should use a diamond burr, which is of 1 millimeter, and drill only 1 millimeter of thickness of the round window bony overhang, not more than 1 millimeter. So now we are going to talk also about the type and diameter of the electrode array. We did a study in Grenoble years ago with Boyer, Schmerber, and myself using cone beam CT, and we imaged 61 cochleas using curved perimodiolar electrodes. And the rate of dislocation in the scala vestibuli was very important, 26%. Whereas whenever you use straight electrodes, so lateral wall electrodes, the rate of dislocation falls to 3%. So if you want to be atraumatic, I advise you to use straight electrodes without stylet inside. And there was a study done in Paris by Nguyen and associates, which showed that hearing results, hearing preservation rates were better when you use thin electrodes compared to thicker electrodes, because the electrode with the thin tip diameter yield lower insertion forces than thick tip diameter electrodes. You have also intrinsic factor which we cannot control, which means inside the cochlea. So this is a view from Arturo and associates. From inside the cochlea, round window is here. So you see there is a deflection of the electrode array by the crista fenestrae, which is a bony prominence in the floor of the round window. So here, this is a study that I did on by using micro CT. Here you see also a very high crista fenestrae, and you see there is a deflection of the electrode array upwards into the scala tympani due to the very high crista fenestrae, as you see here. So I had an atraumatic insertion, but the insertion was incomplete. 2 electrodes were left outside the cochlea because of this very high crista fenestrae here. Some authors advise to drill the crista fenestrae, but also if you drill a lot, you can lose your residual hearing, and you can also traumatize the cochlear aqueduct, which is only 0.5 millimeters inside the round window. There's a factor also, the pars ascendens, which is the first, which is, if you want, it's the first genu of the first elbow of the cochlea. So it's it's between the basal turn and the middle turn in this region here. You have it's increasing, the insertion forces increase at this level here. And you have also friction zones at that level. So and also the scala tympani becomes narrower whenever you cross the pars ascendens. So this can be an obstacle for atraumatic insertion. We see here a work done by Mars in Toulouse, and you see whenever he crosses the pars tendons, there was translocation of the electrode array from scala tympani into scala vestibuli, as you see here. I did a work searching for factors affecting traumatic insertion and for factors that, affecting also completeness of insertion. And you will see that insertion trauma and completeness of insertion are multifactorial. For instance, here in temporal bone number 5, this temporal bone had a very short cochlea. The cochlear duct length was only 27, whereas the average is 30 millimeters. And in this temporal bone, there was no trauma and insertion was complete. Whereas in temporal bones number 8 and 10, they had a very long cochlear duct. And despite this fact, we had insertion trauma, and we had, in one case, incomplete insertion because of Christophanistory and other intrinsic factors which we ignore. Also, in temporal bone number 3, Christophanistory was absent, and despite this fact, we had an insertion trauma. And also, the only factor which was statistically significant was the round window height, because the three temporal bones in which there was insertion trauma, so temporal bone number 3, 8, and 9, these 3 temporal bones had the shortest round window membrane. So we can at least say that round window membrane height is one of the determinant factors that can influence the atraumatic insertion of the electrode array, but it is not the only factor. The speed of insertion. If you see here on a temporal bone model, the higher the speed, so the faster the insertion, the higher are the insertion forces, and inversely, the slower the insertion, the lower are the pushing forces, as you see here. So this is a work done in by the Hanover team in Germany, and also there was another work done also by Rajan, who is in Australia. Now he moved to Europe, and actually he compared a slow insertion speed 50 millimeters per second versus 60 millimeters per second, and he found out that the slow insertion facilitates complete introduction of electrodes and a better residual hearing preservation, and also better preservation of vestibular function. So the slower you go with inserting your electrodes, the better are the results on residual hearing and on vestibular function. And hence the robotic insertion. You know, there are many works that were done on robotic insertion in Tennessee and in France, in Paris. And the first robotic assisted implantation was performed in July 2019 in Paris by Professor Nguyen. And now we have more than 1,000 patients implanted worldwide with the Robotol. They did a first study on the cadaver, and they found out that the rate of migration in the scala vestibuli could reach 80% manually and 40% with the robot. I think that this percentage of translocation is unacceptable. But however, they found out that the robotic assisted insertion was less traumatic than the manual insertion. The duration of insertion is very important, was 36 seconds manually and 80 to 100 seconds using the robotic assisted insertion. Why do I say assisted? Because actually the surgeon manipulates the space mouse. So it's a robotic assisted insertion. It is not an exclusively robotic insertion. The quality of insertion, whenever you pass 30 seconds, your insertion becomes manually jerky. So it's by saccades. Whereas if you use the robot, the insertion is very homogeneous. So you don't have any tremor and any saccades. On the other hand, you don't have any haptic feedback with the robot. So you don't feel any resistance. Whereas when you insert manually your electrodes, you have a haptic feedback, and you can feel any resistance, any fluid inside the cochlea, which is a positive point for the manual insertion. The axis of insertion using the hand is variable, whereas the axis of insertion using the robot is stable, because you define the parameters of the inserter here before inserting the electrode array inside the cochlea. On the other hand, also, the degrees of freedom using your hand are more than 20, whereas using the robot, there are only 6. So you have anterior, posterior, lateral, and rotation, clockwise and counterclockwise. So you have only 6 degrees of freedom, which is very limited as compared to the human hand. There is now currently an ongoing study in France, which is prospective and randomized. We randomize the patients, manual insertion versus robotic insertion, and we'll see at the end of 2025 the results, which is better, manual insertion versus robotic insertion, in terms of hearing results, of implantation trauma, and also in terms of completeness or incompleteness of insertion. So I will tell you in 1.5 years the results. I will show you here a video. This is my second case of robotic insertion 1.5 years ago. So you see there was some ossification into the cochlea, and despite this fact, I drilled the bony overhang here, which was which was huge, and then I used the robotic insertion. I will see the video here. I hope it will work. So this is drilling the round window, which was completely ossified with the 1 millimeter drill, diamond. And then you see I have defined in advance the parameters of the rotation and the translation of the electrode inserter. You have like a trough here to adapt the electrode. This was a Flex 28 electrode from Medel. See, it's a bloody ear. And here you see the insertion starts. So it's a very slow insertion. It lasted about 1.5 minutes, so it's 90 seconds, which is impossible with the human hands. So this is a real-time insertion. I won't show you all the video because it's a little bit boring. So see, now we are in the. I started at the minute 01, and I finished maybe here. And at the end, you should displace the electrode holder from the trough, and then withdraw the trough, the inserter. So it was a very slow insertion. It was average 0.2 or 3 millimeters per second. Remind you that the trauma induced by electrode insertion is not only mechanical, so it's not only the fault of the surgeon, it's also molecular and cellular. So we have an early response, which is related to insertion itself because of the apoptosis. So we have the proteins which induce the apoptosis, which are the caspases, which are proteases. These are enzymes which induce programmed cellular death. You have also free radicals, which induce apoptosis. And you have also necrosis, which is the cell death secondary to acute inflammation. So we have some therapies for this. For the caspase, we have the AM111, which is only used for research now. There are many publications for sudden hearing loss, but for cochlear implantation, the studies are very rare. For the free radicals, some authors recommend the antioxidants like N-acetylcysteine, but the bioavailability of this product in the cochlea is very low. So the clear out of this molecule is very rapid. The only product which is very efficient is for acute inflammation is the dexamethasone. But here also you have a problem of bioavailability, so you should put a lot of dexamethasone either inside the cochlea or transtympanically prior to surgery to have a great bioavailability. of dexamethasone. And you can also have the late response to the cochlear implantation, which is related to a foreign body. The foreign body is the electrodes inside the cochlea. So you can have a chronic inflammatory reaction. You can have creation of extracellular matrix, which is inflammatory. You can have proliferation of fibroblasts around the electrode array as a foreign body reaction. And you can have also scar tissue formation. And scar tissue, we all know that it will increase the impedances. So it will increase the resistance of the electrode array inside the cochlea. And it will decrease the electrical conduction of the electrodes inside the cochlea. So by decreasing the conduction, it will decrease the electrical stimulation of the acoustic nerve. And the only therapy that might help is dexamethasone. So we can use adjuvant treatments. Many studies were done on the hyaluronic acid. Actually, the hyaluronic acid has only a lubricant effect. It will help the electrodes slide inside the cochlea by reducing the friction. But it can also be a vehicle for the dexamethasone. So it can help transport the dexamethasone. The intratympanic steroids are proven to help preserving hearing in animal and human studies. But also, as I said earlier, it depends upon the bioavailability of the product inside the cochlea. Because not too much of the dexamethasone will reach the cochlear apex, for instance. You can use also the systemic corticosteroids, dexamethasone or methylprednisolone, intraoperatively and postoperatively, and it was proven to yield better hearing preservation, and it has a sustainable effect with time. So this is proven to be helpful. Whereas the antibiotics, they have no effect. And despite this fact, over 90% of surgeons worldwide use antibiotics. For instance, in the French Society of ENT and Anesthesiology, we use one single dose of cefazolin or augmentin, amoxicillin clavulanic acid. The American Academy guidelines do not recommend antibiotics. They state that vaccination prior to surgery suffices. Do you use antibiotics during ear surgery in England or not in the UK?
Not really. We don't give antibiotics unless there is an infection. Yes. We don't do the prophylactics.
Yes, this is rather a Latin tendency. France, Italy, and Spain. You know, all the Latin countries use antibiotics.
I don't say that I do it sometimes.
Yeah, yes.
But I can't do it as a regular basis because it's not really licensed to do this.
Okay, great. So this is an image by microscopic fluoroscopy, and you see after cochlear implantation we have apoptosis and we have death of the outer hair cells. You see, it's a drastic death of the hair cells due mainly to TNF and to other proteins which induce apoptosis. Whereas whenever you use dexamethasone with cochlear implantation, you have preservation of hair cells. This is another example of cochlear implantation in the guinea pig, and you see this is the electrode array here. You see this is the in orange you have the vimentin, which is a protein secreted by the fibroblasts, and you see there's a high fibroblast reaction to the electrode array, whereas whenever you use dexamethasone, you don't ever have any foreign body reaction. So dexamethasone and those corticosteroids have a beneficial effect on preserving structures inside the cochlea and on reducing the foreign body reaction. Intraoperative monitoring, how can you monitor the atraumatic surgery? The best way is the intraoperative electrocochleography. So it's an action of the, it measures the movements of the outer hair cells. It's a potential generating by the outer hair cells. And it's here it's in real-time surgery. Whenever you have a drop in the cochlear microphonic, which is the action potential, it can herald that you'll have a loss of residual hearing. So you should stop, withdraw your electrode, and start once again your insertion. So it's a very sensitive and specific means of measurement of traumatic insertion or atraumatic insertion. And in the cochlear limited system, you can use it. You can perform cochleography using the electrode array. So which we call reverse telemetry. So with your electrode array inside the cochlea, you can measure the cochlear microphonic and see whether you have a good potential or not. Another study done by Kim and Associates and Campbell also in Australia. So they showed a very good correlation between audiometric threshold and cochlear microphonic amplitude. And they found out that on average, whenever you have preserved cochlear microphonic, so the actual potential of the outer head cells, you will have a 15 decibel better low frequency acoustic hearing than patients who lost the cochlear microphonic during surgery. So this is a very good means of testing your hearing preservation during real-time surgery. Also, there's image guidance using the handpiece or other systems, but actually it is not very precise, and most studies has been done on temporal bones and not in real-time surgery. You have another means also to use to see if your electrode array is well inside the cochlea and well inside the scala tympani by using the intraoperative cone beam CT. I will show a picture here. This is navigation, so image guidance. And this is the intraoperative cone beam CT, but you see it's cumbersome and time-consuming and etc. But it can help whenever you use, if you have a doubt on the placement of the electrode array. If you want to be sure that whether the electrode array is in the scala tympani, you can use intraoperative cone beam CT. We don't do it here because we have a CT scan facility next to the operative theater, so we can bring the patient intubated into the CT scan suite and do a CT scan intraoperatively. It takes 5 minutes. We have our neighbors in Clermont-Ferrand. They use also fluoroscopy, so you can have real-time radioscopic visualization of the progress of the electrode array inside the cochlea, but it is very radiating and very cumbersome. And actually, you cannot use it. You cannot use it in the operating theater. You should do your surgery in the angiography suite. So it's not very practical at all. And you can also do it remotely by using the Robotol, but it adds time and it adds it's very cumbersome and time-consuming and very expensive. And as I said, in order to do fluoroscopy, you should have angiography suite inside your operative theater and not doing it in a regular room. So it's very unpractical. He is the only one who does it in France. And then postoperatively, you can check. I do it in the OR operative room. I check the integrity of my auditory nerve, and I check if my auditory nerve is stimulable or not by doing impedances. It takes 2 minutes, and then by measuring the ECAPs, the electrical compound action potentials in microvolts. If you have a good potential, this means that the cochlear nerve is being stimulated by the electrodes. If you don't have any ECAP, this means that two things: either your electrodes are outside the cochlea, they are in the superior canal or in the vestibule, or your electrode array is not working. So in both cases, you should do a cone beam CT or CT scan before waking up your patient. So this is a very good tool, which takes 5 to 10 minutes to see whether your nerve is being stimulated or not by the electrodes. I do it before waking up the patient. Post-operative imaging, we do now very on a systematic basis in adults. We do the cone beam CT. This is a study done by my team 2 years ago. So you see here we had a small kinking of the electrode array and a small translocation of the electrodes inside the scala vestibule. See, and whenever you do your impedances, you measure them in the OR, you will have high impedance at this level. At the level of both peripheral electrodes. So you can imagine that your electrodes are not in the good place. This is also another example. We have some kinking of the electrodes and also a small translocation, very limited, into the scala vestibule. So I know it's only 1 or 2 electrodes, but it can affect the definitive result because you will have absence of ECAPs on this restricted to 1 or 2 electrodes. So you should deactivate them and work on the other electrodes. So if it's a medal, instead of working of 12 electrodes, you will work on only 10 electrodes. If it is a cochlear, instead of 22, you will work on 20 electrodes. But it's feasible. I will show you. So these are 2 studies done by the team of Grenoble and Toulouse, and you see on your left the first image was the electrode into the scala vestibule, and the second one the electrodes were in the good place in the scala tympani. And another study in Toulouse here, you see deflection and passage of the electrode array into the scala tympani, which we see very well also on the cone beam CT. So this is a very good tool to see whether your insertion was traumatic or not. It takes 30 seconds or 60 seconds, so it's very fast. You have less artifacts than regular multi-slice CT, and you have much less radiation, 10 times less radiation approximately than the regular multi-slice CT. The limits are you cannot see the spiral ligament, you cannot see the crista, but these are details. And it is operator dependent and also patient dependent. If the patient moves 1 centimeter, you have to redo your cone beam CT imaging. Because the patient is sitting, he's not lying down. The patients are sitting. This is a picture which I did, a histological picture, see on confocal laser microscopy. So you see here, this is a fracture of the vesicular membrane. So at this level, you have rupture of the sensory neural interface, which is the interface between the hair cells and the nerve fibers, and you will have less optimal results in terms of speech discrimination. Here also you have a small elevation, small lift of the vesicular membrane without fracture. So this is less dangerous than this, but also it can affect your speech discrimination because it can hurt the interface between outer hull cells and the neurons, as you will see here. This is scala tympani, scala vestibule, organ of Corti here, and you see when you magnify the image, you see here the interface is at this level here. So if you put an electrode here and you elevate this membrane here, you will rupture all the sensory neurons at this level here, and you will have a less optimal result in terms of especially speech discrimination. So in conclusion, atraumatic surgery is crucial in order to preserve residual hearing, to preserve sensory and neural structures inside the cochlea, so outer hair cells and the neurons upstream to the spiral ganglion. It can also optimize the auditory results and preserve the cochlear structures for future re-implantation in the pediatric population. Your preoperative workup should be very stringent, very serious, and should be customized in terms of cochlear duct lengths of every patient, of facial nerve anatomy, in terms of electrode design, diameter, length, etc. And cochlear microtraumas, as we saw, are multifactorial. They can be mechanic, anatomic, cellular, molecular, and they can also depend on electrode design off stiletto design, perimodular, straight, lateral, etc. Thank you very much.
Well, thank you. Thanks, Alex. This is really comprehensive. Thanks to a lot of people who would like to ask you. We have Kay as well, from Medal. She can answer some questions. So I think so. It's Mr. Ben Amr first hand, and then Mr. Bayoumi. So anyone want to ask, just unmute themselves. Mr. Ben Amr is an otology consultant in Lincoln. And I think so. You would like to ask you some questions. I have 4 questions for you as well. So,
yes.
Thank you very much, Alex, for this. Really, really interesting. People don't speak about like potential complication because they hope everything goes smooth. And a talk like this really highlights a lot of important points. Personally, I don't do any cochlear implant because it's a national things. And I'm afraid you will face a lot of questions out of this lovely talk.
Thank you.
My first question is regarding the deep insertion in the very first slides you mentioned, and to achieve that, would you suggest cochleostomy better? Though you said you don't want blood, you don't want bone dust, you don't want this, but to achieve a deep insertion, would it be better if you have a cochleostomy rather than going through the round window? That's one question. Yeah.
Actually, no, because if you look at cochleostomy, you will lose some of the basal tone of the cochlea, because the cochleostomy, you do it anterior to the round window, so you lose 1 or 2 millimeters, or maybe less of the total length of the basal turn. So you will have less basal stimulation. This is one. Second, as you said, you will enter some bone dust into the cochlea, and no, you don't have to. You should insert the little arrays to the round window, and actually the round window, the average diameter is between 1 and 1.5 millimeters, and the thickest little array is 0.8 millimeters. So it can enter very, very easily throughout the round window. So we don't have to do cochleostomy.
Right. Even can ask add something. Even though because this is my question as well. Even if you have the height of the your round window is very low. You mentioned that if you have low round window, like 1.5 millimeters, it will be very difficult to insert array, and it will lead to rupture. If you don't do cochleostomy in that one as well. Yeah.
Yeah. Actually, whenever round window is fibrotic or ossified or very, very small, or hypoplastic, as in type 3 of Leon, what we do, what we call round window related cochleostomy. So you start by the round window, and then you drill anteriorly.
Okay. So you will be through the round window and go like an extended round window.
Yes, exactly.
Sorry, Mr. Bramer, just to complete the question.
Thank you very much. The second question I have regarding the 4 stages or the 4 levels type of a trauma you mentioned. Yes. How can we secure the electrodes to be in the center of the of the scala tympani? I mean, how can we keep away from the basal membrane? Is there any, apart from what you mentioned, monitoring and using the cochleographies, is there any manual or an advice you give to a surgeon regarding keeping the electrode array away from the basal membrane?
No, the most reliable tool is the cochleography. Personally, I don't do it here. We've done it in the past 1 or 2 times only for research matters, but because we don't have an engineer you need an engineer or an electrophysiologist present in the OR all the time, like in the United States. We don't have this luxury in France.
Okay.
Yes. So the only reliable means is electrocochleography. Otherwise, you can do fluoroscopy, but fluoroscopy that doesn't is not very precise to define the placement of the electrode. Fluoroscopy shows you the progress of the electrode inside the cochlea, but it cannot show you with precision whether the array is progressing into the scala tympani or scala vestibuli. Otherwise, you can do, as in Switzerland, the intraoperative cone beam CT.
Okay. Okay. The final question I have is regarding the very few last slides you show.
Yes.
Electrodes reaching into the vestibule.
Yes.
I mean, you don't need to take them out. You just deactivate them, isn't it? You don't activate them.
Yeah, actually, I didn't have I had this experience once or twice, and no, I withdrew the electrode and I put it back in the right place, because in one of my two cases which I had, there was facial nerve stimulation.
Ah, okay.
And in the other case, I had very low stimulation of the cochlear nerve. So in general, when you have an electrode array in the vestibule, actually it's most of the electrodes which go in the vestibule. So you rather withdraw it and insert it once again.
But I mean, withdrawing and reinsertion isn't that against the concept of atraumatic cochlear?
Yeah, sure, but if you leave them in place, if you leave 10 out of let's say 6 out of 12 electrodes in the vestibule, it's you will have a very bad result, and plus you will have vertigo, plus a high risk of facial nerve stimulation.
Lovely. Really enjoy it. Thank you very much, Sharik.
You're
Thank
welcome.
you very much.
My pleasure. My pleasure.
Thanks.
We have Mr. Bayoumi, Ahmed Bayoumi. He's one of the senior registrars. Ahmed, you can unmute yourself. And
thank you, Mr. Ibrahim. Thank you, Prof, for the interesting, full, informative presentation.
You're welcome.
Thank you very much. I have a question about the post-cochlear implant complication. Interestingly, yes. Infection. I'm aware that acute otitis media, acute mastoiditis, post-operatively should be treated aggressively with IV antibiotics. But my question here is when to declare that the cochlear implant is failed actually, and you decide to take it out and treat the infection, then reinsertion. Is that depend on what investigation? Is it MRI scan or CT scan or both together or anything else? Thank you.
Fortunately, I didn't have any case of mastoiditis, even though I know it's described in the literature. Whenever you have a functional cochlear implant inside the cochlea, you should keep it, because if you remove it during infection, you have a high risk of meningitis or labyrinthitis. So you should keep it in place and treat by antibiotics. What I had in the past, and this is one of the most common complications worldwide, is an acquired cholesteatoma on many years after cochlear implantation. Actually, it was a canal wall down, and a very old canal wall down technique, which I closed, and I put a cochlear implant. And with time, some epidermis appeared, and it became cholesteatoma. In this case, I was not able to keep the electrode, so I removed it. I covered the cochlea with some fascia. I removed all the cholesteatoma, and then I put once again an electrode. And I had
there's an acute infection.
Yeah, because by definition. Yeah, sorry. Just let me finish. By definition, the cholesteatoma is contaminated, so it is an infection. Yeah, please, Abdurrahman.
Yeah, it's just Ahmed was asking about the acute infection. Do you think that at best
yes, if you have middle ear infection, you should treat the middle ear infection with using antibiotics or do a myringotomy. But I think it's better to keep in place the electrode, because whenever you withdraw the electrode, you will have risk of labyrinthitis. You can worsen the case.
Okay, thank you.
Yes. Otherwise, skin infections in the children are very common among the complications worldwide, and I had 2 cases of skin infection, and you can try all antibiotics, and you can do some flaps, and it won't work. So I had to explant the patients, because you have a small biofilm which will grow upon the internal magnet, and it's very hard to remove it. It's impossible to remove it.
Yeah, Yeah, I'm aware it's quite rare, but recently it's increasing. Nowadays, I've seen one of acute mastoiditis and one of the failure of implantation. So thank you for informative answer. Thank you very much.
Yeah, you're welcome. And sorry, because I did not have this experience, so I cannot answer you with my experience.
Thank you. Thank you.
On the other hand, what we do now, if we have a child with otitis media with the fusion, what we do, we stage the operation. We first do put a grommet, and 2 or 3 months later, we do the implantation.
Thanks, Alex. Why you don't have an infection? Because you give the prophylactic antibiotics from the start.
Yeah,
so
we don't.
Yeah, also.
Yeah.
That problem is in the UK, we don't start with antibiotics. This could be the point here.
Actually, yeah, logically you should give, because the middle ear is contaminated by the nasopharynx, whereas the inner ear is sterile. So logically, you should give at least 1 dose of antibiotics. That's what we do.
So next is Mr. Sivaji. He's an ENT consultant as well with us. I'd like to ask.
Thanks, Professor. Thanks, Professor. It's a nice presentation and updating our knowledge about cochlear implant. Just I have a couple of questions. One is influence of hearing preservation in age related. If you are putting an electrode in the pediatrics and then the electrode in the adult or old age, because different pathology, they have a different pathology. Is it any difference in the hearing preservation?
Yes, very good question. Actually, I read a paper on this. The authors, I forgot the name of the author. The authors compared the hearing preservation in the pediatric population and in the elderly population, and they found out that in the pediatric population, hearing preservation rate was much better than in the elderly, because in the elderly you have already some degeneration of the outer health cells and of the cochlear nerve, whereas in the pediatric patient, you have preservation of all cochlear structures. So indeed, in pediatric population, without inner ear malformation, you have better rates of hearing preservation.
Yeah, thank you. And the second question, cochlear malformation. I came to cochlear malformation. It's a very rare, but do you do any different technique to preserve electrode array, different electrode array? You use it for hearing preservation or anything?
Sure. Whenever you have a cochlear malformation, even if you want to do an atraumatic surgery, it's not always feasible, because, for instance, in the gusher ears, I use the cork type electrode from Medel, which is called FORM, F-O-R-M, which is very short, straight, and you have a cork, like the bottle cork, which will plug the cochlea to impede the CSF gusher, for instance. If you, I did also some implantations on a incomplete partition type 1. When you have a cystic cochlear vestibular cavity. So in these cases, the best way is to put an electrode with an array with full electrodes, not only half electrodes, so a full circle of electrodes, in order to stimulate all the lateral wall of the cystic cochlea to have a better stimulation. And in these cases, whenever you have only 1 turn of the cochlea, you should put a very short electrode between 16 and 20 millimeters. Otherwise, the electrode array will go inside the internal acoustic canal. So when you have a cystic cochlea with only 1 turn, you should put a very short electrode array. Also, in the incomplete partition type 2, which we called Mondini's malformation, when you have only 1.5 turns of the cochlea, so you should put a short electrode between 20 and 24 millimeters.
Once again, thank you very much.
You're welcome.
Nice presentation. Thank you.
Thank you very much. Thank you.
Okay, thanks, Raj. So we have Miss Aydin. She's one of the ENT registrars with us as well. I'd like to ask him some question.
Please.
First of all, thank you very much for the great presentation, Professor Karkas. I have one question regarding the neural telemetry. You mentioned that to understand if the electrode is working properly, we need to do a neural telemetry. And if there is a high impedance in 1 or 2 electrodes, then we need to turn them off. Have you ever come across in a situation where there is like high impedance and a lot of electrodes, and what to do in that situation? Do you need to reinsert it or keep it to see the post-op results?
Yes, very good question. First of all, when I do telemetry in the OR, you often have in the basal electrodes, the most basal, the most peripheral electrode. Sometimes you have less conduction of the current because of some air bubbles, inside the cochlea. So you have less current conduction, and you will have some you will have a low ECAP, a low action potential. If you have a very high impedance, you can deactivate the electrode. It was proven in the past that you need at least 4 electrodes in order to stimulate your cochlear nerve. So if you have, let's say, 2 electrodes which are active in the basal turn, 1 in the middle turn and 1 in the apex, which are functional, it can be enough to stimulate the cochlear nerve. But I agree with you that 12 electrodes or 22 electrodes are better than 4. So the worst cases that I had were 5 or 6 electrodes deactivated, and we had a fairly good result. But the more electrodes which are activated, the better is the result, because once again you are respecting the cochlear tonotopy. You are respecting the cochlear frequency distribution.
Thank you very much.
Yes, yeah. And another thing, sometimes you have a, for instance, an ECAP, which is not very good intraoperatively, and whenever you do the telemetry 3 or 4 weeks later, you will have a normal ECAP. This is due mostly to air bubbles inside the cochlea or some blood clots, which conduct less the current. So no worries if you have 1 or 2 electrodes. Actually, the ECAPs are like the wave 1 of the ABRs, that equivalence.
Okay, thank you very much.
You're welcome.
Great explanation. Thank you.
Thank you.
Thanks, Aisha. I think Shadi is well with us, one of the senior registrars with us as well, want to ask a question. Seems to me your topic is very popular. Alex, sorry for this. I know that we're keeping you. It's almost 8 now. Evening, but sorry for you.
No worries.
Yeah, Shadi.
Yeah, exactly, Mr. Ray. Thank you, Prof. Alex, for this comprehensive presentation. So I would like to ask you about your experience. Do you have any prefer to use any specific array or device to make sure that you have less traumatic implantation? And what's your opinion or protocol you can follow regarding bilateral cochlear implant in the same setting? Thank you.
Yes, you're welcome. Yes, in the pediatric population, we use the cochlear system, a small electrode. So it's the Nucleus CI22, 622. It's a straight electrode which is very thin, 0.4 millimeters of diameter, and it's very short. It's 20 millimeters of length. We use this because the body of the implant, the internal magnet and the receivers are small, are very thin, and you have very good connectivity with the HF microphone and with the telephone, with the TV, etc. So in the pediatric population, we use the cochlear system. In the adult, we use the MEDEL, because in the MEDEL you have a great portfolio of electrode lengths. You have too many electrode lengths and diameters. So we do the autoplan or all the software measurements, and we customize the electrode length and diameter according to the cochlear anatomy of each patient. And now I have a resident. She's called Kelly Dawuda, and she is doing her thesis on what we call anatomy-based fitting. So we do a fitting based on anatomy of the cochlea, and we compare this fitting with the standard fitting to see whether by respecting the anatomy of the cochlea and the frequency distribution, we have better fitting results than the standard fitting that we do in all patients. So MEDEL in the adult mainly, and cochlear for children. And now I start to use also advanced bionic in both populations.
Any other questions?
But yes, I will add something. If you had a patient who, I saw a patient yesterday, she is completely deaf. She has anacosis. So in this case, you ought to put an electrode which is very long to stimulate all the cochlea. If you put a, let's say, a 20 millimeter electrode, you will have less stimulation in the middle turn and in the apex. So you ought to put a long electrode to stimulate the medium and the apical frequencies as well.
So now you are following up the specific fitting for each patient.
Yes, exactly.
Adult.
Exactly.
Yeah.
Adult, yes.
Okay, so last question. So,
yes.
Yeah, you mentioned about the straight insertion, like you are using some specific inserter.
Yes.
So you are against, you are against of this technique. I think some cochlea, they have some specific inserter and cochlea.
Yes, actually, the engineers of the Robotol, they designed 3 inserters, one for cochlear, one for Medel, and one for AB, Advanced Bionics.
Yeah, Advanced Bionic, yes, yeah.
Yes, for instance, for the Medel, you have like a trough, like a gutter. For cochlear, you have like a fork, and you put inside the electrode array. For AB, I had not used it yet, but it resembles, it looks like the fork of the cochlear.
Yeah, okay, thank you.
You're welcome. So you have the same arm, which and on which you adapt the inserter. Any other question from your colleagues?
I think so. There is more question regarding to the advanced otosclerosis and severe sensorineural hearing loss. Is there any difficult to find the landmark? What you do for this?
Yes, these are they are a nightmare. The far advanced otosclerosis. Actually, we usually do more drilling of the round window region, and then I recommend the straight electrodes, because if you put because your electrode should be a little bit stiff. If you put a very soft electrode, you will feel some resistance inside the cochlea. So I recommend. Yes, I did some case of it. I used the cochlear CI as Nucleus CI 622, which is a straight, thin, and stiff electrode.
Yeah, other question.
Yes, to overcome the sclerosis inside the cochlea, the resistance.
Great, thank you. The other question with how would you manage the accidental extrusion of the implants electrodes?
Yes. Just to finish with the cochlea, with the otosclerosis, you have to put semi-electrodes, so a semi-circle, not full electrodes, because if you put full electrodes, you can worsen facial nerve stimulation, because the bone is very conductive in these cases. So you ought to put semi-circle electrodes and not full circle electrodes. And second question, Abdurrahman, please.
The second question is about the accidental extrusion of the implant electrodes. If it comes out suddenly, what you can do?
I don't remember, fortunately, any case of extrusion.
That's good. Lucky you.
Yes. Yes, I know of a surgeon in the US. He implanted the patient with the CI 522. It was years ago, and upon arousal, the patient would have a very physical arousal. He was very coughing and moving, and the electrode fell out of the mastoid, and he had to re-operate on him and put him in the right place. In this case, I advise to use another electrode, because whenever it goes out of the cochlea, it becomes contaminated. So we should use another electrode, even though I know it's very expensive, but you don't use another electrode.
Sure.
There was also another question from the audience regarding the bilateral implantation.
Yes.
In France, in the children, you can go for simultaneous implantation in the child, but in the adult, you should go. Implantation should be deferred. So you put the first implant, then you wait 6 months, and you put the other implant in the adult.
Any more questions? Just to remind you that anyone wants the certificate for attendance with the CD points as well, so he can just put his email down there. We're gonna send him the certificate of attendance once we finish. And really, was amazing, Alex. Thank you for the. To be honest,
sorry if
nice
it was very
presentation.
complicated. I don't know if it was very complicated or not, but I tried to do it the simplest possible. But the subject is
no, really, it's really amazing, simple one. You almost take the whole lots of about the cochlear implant in very short hour presentation, which is really nice.
Thank you.
Thanks, thanks again, and hopefully to see you soon.
Yeah, I don't know.
So. Yeah, are you going any of the conferences